The respiratory part 2 PowerPoint. Um, as you remember, the first PowerPoint had a dog with a piece of bread on his face, and now we have a cat. I wanted us to assess this cat. Do we think he might be having trouble breathing? Do you think he might be struggling with his airway? Or is this just what a cat looks like? Well, regardless, we are going to be talking about some different disease processes in this PowerPoint for respiratory. And this will be the content that you will find on your exam 3. So let's go to the next slide. Objectives. I have some questions for you, and then we're going to talk about pneumonia, tuberculosis, cystic fibrosis, laryngitis, lung cancer, laryngeal cancer, and obstructive sleep apnea. So this first part, I have quite a few questions for you guys, but I'm going to go ahead and read through them with you. Prioritize. The nurse is caring for a patient recovering from acute respiratory failure due to an extreme exacerbation of COPD emphysema. The patient was treated with BiPAP during the very acute stage. The patient is stabilizing and receiving 3 liters of oxygen by nasal cannula. The nurse finds the patient breathing slowly, shallowly, and sleeping deeply and is hard to arouse on the next assessment. Pick the correct nursing actions and list inappropriate priority. So I want you guys to look at 1 through 6 and determine, based on these answers, A, B, C, D, which 3 you're going to do and what order you're going to do them in. So A says we're going to obtain a set of vitals, we're going to decrease the oxygen, and we're going to call the primary care provider. Does everybody agree with that? So the rationale, the nurse should quickly obtain a set of vital signs and decrease the oxygen level. We check the vital signs to make sure we know what's going on, right? Then we need to call the provider because we know that these are signs and symptoms of oxygen toxicity. There's a potential for it, so we need to prioritize as if that is a possibility. Obtaining vital signs will provide more information on the patient's status, and it is vital to determine the treatment. Since this is a COPD patient, the respiratory drive is hypoxemia, not hypercapnia, so it is likely that the patient is receiving too much oxygen, which causes a decrease in the respirations. The provider needs to be updated to evaluate further interventions for the patient. Another couple questions here. The nurse recognizes that the first physical compensatory mechanism of decreased oxygen delivery is which of the following? The nurse recognizes that the first physical compensatory mechanism of decreased oxygen delivery is which of the following? Is it A, increased heart rate, B, increased respiratory rate, C, decreased heart rate, or D, decreased respiratory rate? Good, it is respiratory rate. It is the first physical compensatory mechanism of decreased oxygen delivery, right? You need more oxygen, you're going to start breathing faster. What's the second compensatory mechanism? Heart rate, absolutely. All right, what is the predominant diagnostic test for lower airway disorders? Is it A, ABGs, B, chest x-ray, C, pulmonary function tests, or D, oxygen saturation? The answer is C, pulmonary function tests, right? Lower airway disorders include asthma and COPD, and pulmonary function tests include the FEV1 and FVC. So the major diagnostic test for lower airway disorders is the pulmonary function test because it's going to assess the air movement. Let's go to the next one. The nurse assesses 3 asthmatic patients who present to the emergency department with the following symptoms. Which patient should the nurse treat first? Is it A, patient with oxygen saturation of 91%, B, patient with a peak flow less than personal best, C, the patient with inspiratory and expiratory wheezes, or D, patient that is able to speak in short sentences? Remember, we're looking at asthma patients. So you need to determine what is normal for an asthma patient and what is not. What is the most important thing for the person or for the nurse to go assess? So the answer is C, patient with inspiratory and expiratory wheezes. So all of these symptoms are respiratory compromise in asthma. The patient with inspiratory and expiratory wheezes is demonstrating a severe asthma exacerbation and they need immediate treatment. And what would you grab for this patient? Albuterol, very good. A short-acting beta-2 agonist. Okay, next question. A patient with COPD is given a high dose of oxygen in response to a low SpO2. What is the priority intervention for this patient? A, cardiovascular assessment, B, assessment of respiratory rate, C, medication administration, or D, respiratory therapy referral. The answer is B, assessment of respiratory rate. So all of the other ones are important, but the priority assessment or intervention for the COPD patient receiving high levels of oxygen is the respiratory rate. The respiratory rate will decrease due to the fact that his breathing is stimulated by a decrease in his oxygen level. With high levels of oxygen, the patient has lost his stimulus to breathe. All right. Here are a bunch of other questions. So what is the nurse going to use to treat COPD? Think about all the medications. So we know oxygen is one. Almost all of our COPD patients are in some form of oxygen, even if it's a small amount of liters. Let's look at bronchodilators, right? We talked about they have long-term acting, or they have long-acting ones, and they have different medications that will bronchodilate, that will help. Mucolytics, for our bronchitis patients, we want to break the protein linkages in the mucus to help thin them. And expectorants are going to thin the mucus as well. So we want two things for our bronchitis patients to help thin the mucus so that they can cough them up. And we want to ensure that our patient can cough before we give them mucolytics, right, or expectorants. So next question. What will the nurse assess if a patient with the flu is not tolerating treatment or getting better? Patient has the influenza. What will you assess? What will you hear? There's a tip for you. If the patient is not tolerating treatment or getting better. Crackles throughout the lung. Yes, very good. Okay, patient is showing signs of severe asthma attack. Name 3 things you will do in order for this patient. So what position do they need to be in? Make sure they're in high Fowlers, right? Maybe they're laying down on their side. Get them up, high Fowlers. It's the next thing that you need to do. Correct, you need to assess their lungs. Are they wheezing? Could this be something else? Then we need to make sure that we give them some oxygen because they are going to be struggling to breathe. Okay, name 3 signs of early hypoxemia and what lab value you will look at to determine this. Hypoxemia will show agitation, restlessness, tachycardia, and tachypnea. That's the mnemonic of rat. And you are going to assess the PaO2 to determine that your patient is hypoxemic. And according to your FA Davis, the PaO2 less than 80 is going to indicate hypoxemia. When educating a patient about breathing through the nose and out the mouth through a straw, what are you teaching? Pursed-lipped breathing, very good. And what does this do? Helps with prolonged exhalation, yes. And who do we teach this to? Very good, our COPD patients. Okay, that was an easy one. All right, so name 3 signs that a patient has emphysema and 3 signs that a patient has chronic bronchitis. So 3 signs that you can say for emphysema: barrel chest, increased CO2 retention, shallow breathing, skinny or low BMI with the big chest, which is a barrel chest, and anxiety. And then chronic bronchitis, cyanotic, obese, increased respirations, CO2, and sputum. Okay, let's talk about pneumonia. So what are some risk factors for pneumonia? Really young, really old, right? They have a decreased elasticity and thickened alveoli, chronic lung disease, people with decreased level of consciousness, they can't turn, cough, deep breathe, they can't move around. The immunocompromised patients like our diabetics, people on steroids, autoimmune disorders, these are all at a higher risk. How about immobile clients or vented clients? How about people that just aren't vaccinated or immunized? People have had a recent exposure to infections, environmental contaminants, or even substance use. These will all put people at a higher risk for pneumonia. We have two types of pneumonia, community acquired and healthcare associated. So just be familiar with, if you have one over the other, there's different ways to prevent them. So what is the problem? What is pneumonia? Well, you have an inhaled viral, fungal, bacterial infection. You can have three different types of pneumonia. Three things can cause pneumonia. Inflammatory process in the functional lung tissue that produces excess fluid triggered by infectious organisms or aspiration of something irritating like a foreign object or fluid, so aspiration pneumonia, can lead to edema, exudate, like blood, white blood cells, pus that fills the alveoli. You can see that in the pictures. In this top left picture, it says alveoli with fluid. So it can be a complication or a primary disease. So think about how this could be a secondary thing. Something starts as one thing and then turns into another, or turns into pneumonia, or leads to pneumonia. How do you know your patient has pneumonia, and what will you assess? So some signs and symptoms would be anxiety, fatigue, weakness, chest discomfort from coughing, hypoxia, confusion, usually in our older adults. The sputum is going to be yellow-green, thick, purulent. They can have a productive or non-productive cough, crackles and wheezes, shortness of breath, pleuritic chest pain. Other labs or tests that you can assess, sputum culture can come back positive. Your CBC can show an elevated white blood cell. Your PaO2 could be less than 80 to show hypoxemia. A blood culture could determine if the infection has spread. Sepsis, anyone? Yeah. Your electrolytes, it could indicate possibly that the patient might be dehydrated. Maybe we have a low sodium due to the dehydration. Your chest x-ray could show consolidation, and that might take a few days to actually show up on the x-ray, or a pleural effusion on a CT as well. So how do we fix this problem? I know. High Fowlers, you guys always tell me that, right? Oxygen, yep, because you said that they would have a decreased O2 sat. Breathing treatment, what kind of breathing treatment do we want to do? Okay, well, if we have inflammation, we could do an inhaled corticosteroid. Very good. What else could we do? We could use a bronchodilator. Yep, a short-acting beta-2 agonist. Very good. Antibiotics. Very good. After you do your blood culture ×2 and you know what's causing that pneumonia, get those antibiotics on board. Monitor for C. diff and kidney function. Very good. Yes. Let's see. Can we increase periods of rest and increase nutrition and fluids for this patient? Yes, yes, yes. Fluids, fluids, fluids. You guys learned this in 5th semester, that your sputum secretions or your mucus will thin if we drink more fluids. We want them to rest because that's always good for someone who's ill or struggling to heal. We want them to increase their calories because they may not be intaking as much food. If they're taking ipratropium to help them to have the open airways, then we definitely want to tell them to suck on hard candies, right? You guys remember that from the previous one. If your patient has pneumonia and they have a tracheostomy, can I get a sputum culture from the trach? Yes, I can. Very good. Yes, absolutely. When you guys do a suction, you guys can get a sputum culture from when you suction. It's pretty cool. They actually have a special tool, and we don't have one to show you guys in lab, but we saw them all the time with COVID because it was just a lot easier that way, and we were taking sputum cultures left and right. Okay, so how do we prevent this problem, and what type of patient education do we need to give to a patient with pneumonia? Hand hygiene, get immunized, rest as needed, don't smoke, avoid crowded areas, take your medication as prescribed. Pretty straightforward, right, guys? So if you look at this next page, it shows you all of the wonderful things that we just talked about. And I'm going to move on. Okay, well, I hope I didn't really mess that up. I'm sorry, guys. Okay, so it's not on there, so I'm going to just make sure that I go through this with you. The slide that has all of the tests on it, your lab tests, we're going to talk about how you know that the patient has an active form of TB. There are only 3 ways to confirm an active disease, and that's going to be the quantiferon TB Gold. It's going to determine whether the infection is active or latent. Results are available in about 24 hours, and it's a blood test. You have an acid-fast bacilli smear, and if it's a positive acid-fast, then you have an active infection. This is determined by the positive culture for TB, and then a chest x-ray. If they have cavitating lesions and formation of gas-filled space within the lung tissue, which is in that picture over here, they have an active presence of the disease. Now, the one that we always use is the Mantoux test, M-A-N-T-O-U-X. And this is where we take the PPD. And in 2 to 10 weeks of exposure, the client or patient or you will be positive. It's an intradermal injection. It needs to be read in 48 to 72 hours. If you have a positive in duration of 10 millimeters or greater in diameter, you are considered as having a confirmed immune response to TB. Remember, this does not confirm an active disease. False positives can occur, especially if they've been vaccinated with the Bacillus Comet-Guerin vaccine. So they must get a chest x-ray or the quantiferon gold to determine active presence of the TB. Latent TB can have a positive Mantoux, so meds need to be given to prevent active disease from developing. So once again, if you have 5 millimeters or greater on your Mantoux for your immunocompromised patients, it's considered positive. If you have 10 millimeters or greater in diameter and you're just a regular person, you are considered positive. After you get a positive test, you need to get a chest x-ray or a quantiferon gold to determine active presence of TB. The latent TB patients with latent TB that have a positive Mantoux, meds need to be given to prevent the active disease from developing. All right, so how do we fix the problem? Well, the very first thing you need to do is immediate isolation. You guys know that the goal is to cure the patient and minimize their exposure and transmission. So we need to put them on airborne precautions, which means an N95 mask for you, negative airflow room for the patient, and a surgical mask for transport when they leave. Having humidified O2, they need to take their prescribed meds. It's a 4-drug regimen. They need to have adequate nutrition. They need lots of protein, iron, vitamin C and B. They need a nice, good, balanced diet. How do we prevent the problem, and what patient education does this patient need? So exposed family members need to be tested. And this seems pretty obvious, right? Even if they're not immunocompromised, we still want to ensure that they don't have a latent TB or active TB. A basic 4-drug combination is recommended for the treatment of TB, and it must be taken for the prescribed time, which is a full 9 to 12 months, possibly up to 2 years, because we don't want a drug-resistant TB to occur. You guys learned about superinfections. That is something that can happen if our patients do not take these drugs exactly as they are prescribed. They have to get sputum samples taken every 2 to 4 weeks, and after 3 consecutive negatives, so they have to have 3 consecutive negative sputum samples, they will be considered not contagious anymore, and they can go back to normal life. They need to use hand hygiene, cover their mouth, use tissues, throw away all their dirty stuff in plastic bags. DOT is used to help compliance for medications. If you have patients that they're not sure if they're actually going to take the medications the way that they need to, or they may forget, or they don't seem like they're going to be compliant, they'll send these people out. It's transitional care. So home health care nurse aide sees patients every day to ensure that the meds are being taken the way that they need to ensure that we do not create a drug-resistant TB. All right. So I'm going to I know this is, we are not done yet, but I'm going to stop here for this one. Okay, so we have a question. The nurse understands that the priority intervention with the patient with TB is which of the following? A, antibiotic administration. B, initiation of isolation. C, TB test. Or D, chest x-ray. You're right. Initiation of isolation. Absolutely. 100% what needs to happen. So some of these tests. Okay, so I kind of skipped through because my PowerPoint's not letting me just keep clicking like I normally do. So just go through the case study in the previous pages on the different slides and make sure that you can answer those questions about Mr. Markham, okay? But right now we're going to talk about cystic fibrosis. Top right corner, there's a picture that says cystic fibrosis is like drowning on the inside. And if you look at the patho of it, it's exactly what it sounds like. So the people at risk are men and women, Caucasian, and it is hereditary. 2 carriers have a baby, 1 out of 4 will get it. So if we have 2 carriers of the CFTR gene, 1 out of 4 babies will get it. 10 million carriers that don't know they have it out there, okay? It's a recessive hereditary inherited chronic disease that affects the lungs, digestive tract, and reproductive system. It creates thick, viscous mucus or thick, viscous mucus. That's how I always try to remember it. So just put TH where all the S's are and you'll sound funny, but you'll probably remember how thick and terrible the mucus is that these patients get. And it clogs the lungs and obstructs the pancreas. 85% of deaths occur due to respiratory problems. 85%. Disease affects the exocrine glands and secretes hormones into the ducts, so your sweat, your salivary, and your pancreas glands. It results, the defective gene, the CFTR gene, results in a thick mucus buildup on the cells, and then that gene blocks transport of those enzymes, which leads to decreased absorption of food and potentially diabetes due to an insufficient secretion of insulin. The mucus will plug the airways, inflammation, and bronchiectasis, which is chronic dilation of the bronchioles, usually occurs in the upper lobes first. And if you look at this picture, if you think about fluid in these lungs just sitting there, sitting there, sitting there, what is your patient going to be at risk for? Pneumonia. Very good. Fluid's not going anywhere. It's just chilling. So yeah, it's going to get an infection. It's going to create, you see the bacterial infection that has occurred in these bronchioles here? Thick, sticky mucus. It's blocking the airways so they can't breathe. They're drowning in mucus. Some signs and symptoms of patients with cystic fibrosis, besides the ones I've already talked about, you're going to hear persistent cough that produces thick sputum, wheezing, a decreased ability to exercise, repeated lung infections, and inflamed nasal passages. Don't forget that it can also affect the pancreas and the GI tract. So they're going to have foul-smelling, greasy stools, or steatorrhea, poor weight gain and growth, intestinal blockage, generally in our newborns, and severe constipation can occur. Steatorrhea is foul-smelling, greasy stools. It is not diarrhea, okay? Steatorrhea is just foul-smelling, fatty, greasy stools because the body is unable to absorb them due to the defective gene blocking the ability to absorb, okay? So your patient's going to have constipation, poor weight gain and growth, steatorrhea, repeated lung infections, decreased ability to exercise due to not being able to breathe due to the mucus blocking their airways, thick sputum, lots and lots of thick sputum, and wheezing. A test that you can do to determine if your patient has CF, even with these signs and symptoms, is the CFTR will be found that gene, that defective gene, is found in sweat glands. So they will do what is called a sweat chloride test. A high level of sweat chloride test equals cystic fibrosis. And they actually have mandated CF screenings in newborns since 2010. How do we fix this problem? We're going to give mucolytics, so mucomist, to thin the secretions. We're going to give anti-inflammatories like ibuprofen. We're going to do antibiotics for chronic pulmonary infections. We're going to give fat-soluble vitamins like A, D, E, K vitamins because we just said that they have fatty stools because our body is unable to absorb those. So we need to take them in pill form. Pancreatic enzymes, same thing. I already had said that the gene blocks the transport of the pancreatic enzyme, so it can't break down the food. It can't break down the food to be able to be absorbed in the body. So we need to add those enzymes every time the patient goes to eat something. CFTR modulators. These are drugs that are attempting to correct the malfunctioning protein of the gene to lessen the effects that it has on the body. The last ditch effort for this is surgery. They can have a lung or a pancreas transplant to extend the patient's life. But the problem is there's such a risk for surgery due to all of their other organs struggling. And remember when we talked about it last week in class, if a patient is on a ventilator, if a patient is on a ventilator and they're already struggling with another respiratory disorder, they may have trouble coming off of it. Your patient's going to have to be put on a ventilator for surgery to have a lung transplant or a pancreas transplant. They may not be able to come off the ventilator. So cystic fibrosis is a very sad disease. There's a lot of YouTube videos out there if you want more information. But that's all there is for cystic fibrosis. All right, next slide. We have laryngitis. Ooh. We talked about the trach a little bit, and you can see in this picture and the following pictures where the larynx is located. What a normal larynx looks like up here on the top left, what a normal looks like, and what the inflammation or one with inflammation looks like. People that are at risk for laryngitis are people that have prolonged periods of talking, which is usually seen in teachers or lawyers, having to scream or having to talk loudly as a result of environmental noise, throat or lung cancer. Laryngitis is a symptom of this. Patients that have been intubated, so those ET tubes go straight down and it can cause irritation. Upper respiratory infections can cause laryngitis. Environmental pollutants, GERD, and asthma inhalers can all cause laryngitis. So what exactly is it? It's very straightforward, you guys. It's just the inflammation of the mucous membranes of the larynx. So when someone is very hoarse, it's laryngitis, okay? They have a dry throat, difficulty swallowing and eating. They may have a fever if it was an upper respiratory infection, a cough, post-nasal drip. Some people are very familiar with that when they have an upper respiratory infection. Fatigue and malaise are all signs and symptoms. If the symptoms of acute laryngitis last longer than like 5 to 10 days, they need to go see their doctor to make sure that, after doing appropriate treatment and voice rest and stuff, that there is not a malignancy causing this issue. So if your patient's complaining of hoarseness, absent voice, due to an upper respiratory infection, we can do a visual exam of the larynx by an ENT doctor. So they'll use the laryngoscopy to check for polyps, inflammation, tumors, and then an X-ray or a CT for further diagnosis. So how do we fix this problem? Voice rest. That means don't talk, don't scream, don't sing. Add moisture to the air in the home with a humidifier or a vaporizer, and drink lots of fluids. Avoid smoke and exposure to secondhand smoke. We can use antibiotics if it's an upper respiratory infection that's causing the problem. And we want to make sure that after extubation, so after we've extubated, taken out that ET tube for our patients, that we have that emergency airway equipment available at the bedside, because the hoarseness could lead to the hoarseness or the irritation of the larynx could turn into where it's inflamed and covering the airway or closing the airway, which will lead to stridor, which is that high pitch sound, right? Where the right? Okay. Which is an emergency. So we must make sure we have our emergency airway equipment available at the bedside. For this patient, if they're in the hospital, we want to make sure that we provide them a pen and paper for talking because we don't want them talking too much. Right? And the only education, or the biggest education after we, fix the problem, is to make sure that if it lasts greater than 5 days after the appropriate treatment and voice rest, that we determine that there is not a malignancy present by having them go to the doctor to look further into it. Okay, next slide. The nurse is aware that there are several causes of laryngitis. Which of the following can cause laryngitis? Select all that apply. Is it A, food allergies, B, upper respiratory infection, C, environmental pollutants, D, GERD, or E, obstructive sleep apnea? The answer is B, C, and D, upper respiratory infection, environmental pollutants, and GERD. Good. Next slide. Now we're going to talk about laryngeal cancer. So the risks that come with this, the number one reason, can anyone take a guess? Smoking seems to cause a lot of stuff, right? But it is 4 times more likely in men that are of older age, people with GERD, people that are exposed to chemicals, immunocompromised people, and heavy drinkers. So what is laryngeal cancer? The lower part, you'll look on the right here, you'll see where it says larynx, but it's the lower part of the larynx, it's the subglottis, and it's the area located between the vocal cords and the trachea. And I have a picture here so you can kind of get a visualization of what they're talking about. It says that the laryngeal cancer usually originates from the entrance to the esophagus. So you see where there's the esophagus here, and you see the trachea here? This is where the laryngeal cancer is going to originate from. On this picture to the right, you can see a normal larynx, and then you can see one that has what's it called? A tumor. You can see the tumor on the left side here on the right, in that far right picture. So signs and symptoms for your laryngeal cancer patients: hoarseness or change in the voice that does not resolve in 2 weeks. Voice changes that include a lower than usual pitch and raspy hoarse sounds, a persistent sore throat, a constant cough, pain with swallowing, ear pain that does not go away, difficulty swallowing, trouble breathing, a lump or mass in the neck, and weight loss due to difficulty eating. So make sure you know the difference between a laryngitis and laryngeal cancer, okay? Because some of them have similar effects. Some labs and tests that are going to indicate that it's laryngeal cancer. We're going to do the laryngoscopy or laryngoscopy and we're going to see nodules, polyps, bleeding, or tumors. If we see a tumor, we'll do X-ray, CT, MRI, and then we can try the PET scan. Remember earlier when we talked about cancer and I said that we have a scan that kind of lights a person up like a Christmas tree if they have malignancies throughout the body and not just located in one place. And then of course we can take a clipping of that tumor or a biopsy of the tumor to determine what's causing the issue. So if it is cancer, okay, so how are we going to fix this problem? Well, laryngeal cancer is a cancer, so let's think back to what we talked about in that first week of class, actually. Radiation, it's going to eliminate those cancer cells, right? Especially if we have small tumor. They're going to be on chemo or radiation 5 times a week for 6 to 8 weeks. It's going to have prolonged tissue healing. They're going to have a sore throat. They're going to have difficulty swallowing. The chemotherapy is going to be used to shrink our larger tumors. Then we would do radiation or palliative care, depending, right? We want to control the cancer and relieve the symptoms as much as we can. A laryngectomy, we will remove the tumor, maintain function of the larynx. But they're going to end up with a trach. So let me, so you guys can see here, here's my larynx. Find the one that says larynx, okay? It's over here on the left. And you see how when they remove that the only way to have an airway after that is to put in the trach. And you see where the trach goes on the right here, tracheostomy stoma, goes right there. So they have to have a permanent tracheostomy. It only makes physical sense when you look at where everything is located, right? I also want to point out where your esophagus is and where your trachea is. Do you see the yellow tube? The food goes down where the yellow arrows are, and the air follows the blue arrows. The air goes down the trachea. Food goes down the esophagus. So when your patient has a trach, as you can see in this right picture, After their laryngectomy, your patient gets a trach, they can eat food fine. They're missing their larynx right here. Larynx, vocal cords, they're gone as soon as they get a trach. So they have to use special communication devices. The electrolarynges are mechanical devices that can be placed against the neck, and they're used to create vibrations in the air to create words so your patient can communicate with a tracheostomy. Part of the education after having laryngeal cancer, we need to teach them about tests and procedures throughout the process. We need to make sure that they have writing boards because they're not going to want to speak because it's going to be painful. We need to make sure we teach them to stop smoking and drinking alcohol. They need to learn how to do trach care and suctioning because this is a new way of life for them. It's going to be scary. They may not even like the way they look anymore. They may be worried about how they interact with people. Everything is going to change for them. So we need to make sure that we are very supportive of this new life that they're going to have. With trach care, good care is essential to maintain patency and decrease infection. So this tube right here, where he says tracheostomy stoma, anything that goes down that goes straight down the trach into the lungs. So they're much higher risk for infections. Humidity is going to help to assist in moistening the respiratory secretions and pulmonary hygiene, which will facilitate secretion removal. So we want to make sure that the oxygen that they use has at least 10 milliliters of humidified oxygen. We need to make sure that the patients are also aware that they need replacement equipment in case there's a dislodgement of the tracheostomy. So the obturator and replacement trach must be at the bedside in case of dislodgement. We always have to have suctioning at the bedside because if your patient cannot cough up those mucus plugs or cannot cough up the mucus through their trach, it can end up closing their airway. Okay, let's go to the next question. 8 more slides. Okay, case study. The nursing plan of care for a patient diagnosed with lung cancer includes which of the following? Oh, we haven't talked about lung cancer yet. Okay, let's see if you guys can answer this because that'll be the next slide. A, education about disease management. B, frequent assessment of pain levels. C, reminders that recovery is coming soon. D, frequent assessment of oxygenation. And E, weaning from oxygen because the disease is terminal. So the answer is A, education about disease management. B, frequent assessment of pain levels. And D, frequent assessment of oxygenation. And we'll get more into on the next slide right here. Oh, isn't she the sweetest little old lady? She reminded me of a patient that I actually took care of when I worked on the oncology floor, and my heart just went out to her because she was over 65, which is one of the risk factors, but she never smoked a day in her life. So your risk factors for lung cancer, most prevalent in people over 65, secondhand smoking, asbestos, and occupational pollutant, but smoking is the biggest one, right? Laryngeal cancer and lung cancer, smoking, okay? The patho is just uncontrolled growth of abnormal cells in the lungs that cause lung cancer, okay? There's 2 kinds. We have non-small cell lung cancer, which is going to affect 85 to 90% of people. It's the most common type of lung cancer. It's diagnosed early, has a 5-year survival rate. 5 years, guys. 5 years. 5-year survival rate. And then there's small cell lung cancer, which affects 10 to 15% of people, and only 5 to 10% survive for 5 years. You can see my little picture here. On the left, it says rises in the outer region of the lung, may look like pneumonia on a chest x-ray, and it's more common in women, and that is the one that my lady had. And then on the right, you can see that it says that it's the most aggressive type is small cell, rapidly growing to many sites within the body, and it's strongly related to cigarette smoking. So how do we know our patient has lung cancer? What are we going to assess in them? What are we going to hear? What are we going to see? Patients can have a new cough that does not go away or changes in a chronic cough. So they might have a cough, but it changes. Hemoptysis, so they're going to cough up blood, shortness of breath, wheezing, hoarseness, and chest pain. A headache and bone pain may also be present in these patients, and weight loss is very common because they are not feeling well. We diagnose this with a chest x-ray CT pulmonary lesions will be found. A cytology test, we're going to check the tumor cells to see what they are. A bronchoscopy will show us a visualization of the tissues. Bone scans and abdominal scans can show if there has been metastases. And then, of course, the PET scan, again, can be used to determine if there have been metastases as well. This is going to be more of a palliative type of fix. This is, like I said, 5 years is the survival rate for people with lung cancer. So we need to keep them comfortable. Pain control and palliative services are huge for these patients. Radiation therapy and chemo are options, but even with surgery, they still don't have much time. So for surgery, they can do a lobectomy, so we can remove an entire lobe, and pneumonectomy, which will remove an entire lung, and then a wedge resection, which will remove a small section of a lobe. We need to educate our patient on over-the-counter medications, nutritional needs, smoking cessation, controlled breathing, palliative and death and dying education. Next slide. The nurse is aware that the greatest risk factor for laryngeal cancer is, yes, tobacco use. Very good. All right, we have a few more things. You guys kind of already are a little familiar with obstructive sleep apnea, so this one shouldn't be too terrible, but let's go through it. What are the risk factors for OSA? Obesity, history of AFib, dysrhythmias, type 2 diabetes, heart failure, smoking, men aged 40 to 65. Men that smoke, that are obese, and already have a heart problem, right? What is OSA? What is the problem? We have upper airways that narrow or collapse that increase the resistance to airflow, meaning that the airflow is blocked to the lungs. Their work of breathing is unable to overcome the resistance. So work of breathing is, right? And if you don't have a strong enough work of breathing, in this case, it doesn't matter. They're still unable to overcome that resistance, that airflow resistance. So the narrowing can occur in the retropalatal region, the retroglossal region, or the nose. Periods of apnea result in no gas exchange. And if there's no gas exchange, there's no oxygen or CO2 exchanging, right? And if you remember, respirations occur at the alveoli. That's not occurring either. So then the body is not getting oxygen throughout its system, right? We're not perfusing oxygenated blood. So that will lead to hypoxemia and hypercapnia, which is an increased CO2 in the blood, which can also lead to, if I'm holding on to CO2, what do I have? Acidosis. Yay, very good. Okay, so signs and symptoms, loud snoring, right? We always talk about the wife complaining about the husband who's snoring really loudly. Witnessed apnea, meaning that a family member has seen apneic episodes. Gasping during sleep, reoccurrent waking during the sleep, choking, daytime sleepiness, okay? To diagnose this during a sleep study, they'll have to recognize 15 or more obstructive sleep events per hour in order to state that they actually have obstructive sleep apnea. A polysomnography is what a sleep study is, and that is how they diagnose this and determine that the patient has this problem. Okay, so how do we fix it? Our primary fix for this is a CPAP, continuous continuous positive airway pressure. I'm sorry guys, I just drew a blank. So this is going to keep the airway open with continuous pressure. We need to watch for skin breakdown around the mask. We need to make sure that they bring their CPAP with them to the hospital, because this is very important that they have their CPAP with them. We need to teach the patients that they need to lose weight. It helps tremendously for their ability to breathe, and they need to manage that weight being off, okay? We do not want them in supine position. We want them to use pillows. We don't want them to drink alcohol or use sedatives before bed because they're already struggling to breathe. Our goal for this patient, if you think about what the problems were, is we want them to have a decrease in the daytime sleepiness. We want to improve their sleep patterns. Another thing that they can do is they can do surgery where they can actually go in and remove excess tissue in the airway that's interfering with maintaining the adequate airflow. Crazy, huh? Bariatric surgery to facilitate the weight reduction is also a consideration for these patients. A complication that can occur is uncontrolled hypertension. And I want you to think about why uncontrolled hypertension can occur if the patient has increased pressure and they can't get the pressure off of their body. Think about what we talked about in last week's Respiratory Part 1 lecture and see if you can come up with that answer. All right. Add a question. A nurse is providing patient education regarding OSA to a newly diagnosed patient. Patient understanding is indicated by which of the following statements? A, I guess I should really lose weight. B, I do not have to lose weight as long as I can use CPAP at night. C, a glass of wine in the evening will help me sleep through the night. Or D, I will not have to take my blood pressure meds if I use CPAP at night. We're looking for the patient understanding is indicated by which of the following? And the answer is A, I guess I should really lose weight. Good job. So here's a fun picture of sleep apnea. Okay. We just talked about the majority of these things, okay? We're just talking about obstructive for this class, but just be familiar that there are different types. There are 3 types of sleep apnea: obstructive, central, and mixed. And then let's go to the next. Okay, so this is back to Mr. Harold Markham. I'm going to let you guys go ahead and finish this off. These are the questions to finish off the last case study. And then this one is also one of those questions. And these are all in your FA Davis or in your Davis Advantage, okay? The case study came straight from Davis Advantage. So my recommendation is, after listening to this PowerPoint, see if you can answer the questions throughout the PowerPoint and then go to your Davis Advantage and check your answers. All right, well, I've enjoyed talking to you guys about respiratory part 2 and the other diseases. I hope you guys have a wonderful time doing the charades game that I have all set up for you with Professor, I only know her first name, so I will put it in an announcement for you guys. Her first name's Natalie. I just don't remember her last name. All right, guys, I'll see you in about a week or 2. Well, a week and a half. Okay, bye.